Welcome back, learner, to the deep dive. Today we are looking at a medical blind spot so massive it affects millions of women, yet it is treated like an absolute taboo.
Yeah, it really is. It's wild how little it's talked about.
Right. Usually when we talk about a medical diagnosis, there's this underlying expectation of precision. It feels like almost like engineering.
Oh, for sure, like a very clear cause and effect.
Exactly. If you break your arm, the x-ray shows that jagged white line. The doctor points to it, puts a cast on it, and you have a clear roadmap for healing. It is comforting because we like things to be visible and easily categorized.
Yeah, we want a physical problem we can just point to.
Right. But step into the world of women's intimate health, specifically postpartum recovery, and suddenly that x-ray machine is completely broken. We are looking at a diagnostic landscape that is murky, dismissive, and incredibly frustrating.
Murky is the perfect word for it, honestly.
Specifically, we were talking about a highly common but rarely openly discussed reality, the painful long-term aftermath of poorly healed episiotomies or perineal tears after childbirth.
Yeah, and for so many women, the physical tear might technically be considered, closed by a doctor at like a 6-week checkup.
Right, they just glance at it and say you're good to go.
Exactly. The switches have dissolved, the skin is physically touching, and the chart just gets a check mark. But beneath the surface, the tissue remains rigid, tender, and deeply uncomfortable.
Which is just awful.
It is. It becomes this silent epidemic of localized pain that just gets dismissed as a normal part of having a baby. The patient is left dealing with functional impairment, but because there is no gaping wound, the medical system often just, shrugs.
We are not going to just shrug today. Our mission for this deep dive is to investigate a potential solution that sounds, frankly, like science fiction.
It really does.
We are looking into whether a regenerative treatment derived from fish DNA, specifically a molecule called a polynucleotide, can actually reduce that scar contracture, relieve the local tenderness, and restore intimate comfort for these women.
Which is such an exciting frontier.
It is. And to do this, we have pulled together a really fascinating stack of sources. We've got real-world clinical studies focusing on vaginal atrophy and tissue regeneration, comprehensive dermatological reviews on scar modulation, and the actual clinical protocols being used right now at cutting-edge aesthetic and intimate health practices.
Like the Doral Clinic in Florida. And various Harley Street clinics in London.
Right, exactly.
And I think the diversity of these sources is what makes this so compelling. We are bridging the gap between advanced dermatology, regenerative medicine, and gynecology.
It's all coming together.
Yeah. By looking at how these DNA fragments operate on a cellular level across different parts of the body, we can piece together exactly why they are showing such unprecedented promise for the pelvic floor.
Okay, let's unpack this. To understand how marine DNA could possibly fix a perineal tear, we first have to understand why these specific scars can become so painful and rigid in the first place.
Right, the root of the problem.
Yeah, like when someone tears during childbirth or has a surgical cut like an episiotomy, what is actually going wrong during the healing process?
Well, to get to the bottom of that, we have to completely reframe the timeline of how a scar heals.
Okay.
We tend to think that once the skin closes over in a few weeks, the healing is essentially done. But according to patient guidance from Memorial Sloan Kettering on surgical scars, a scar actually continues to actively mature and heal for 12 to 18 months after the initial trauma.
Wow, 18 months. It's a long time.
It's a highly dynamic, ongoing biological process. You have the initial inflammatory phase to clear debris, then a proliferative phase where new tissue is built, and finally a long remodeling phase where that tissue is refined.
So it's not just a quick fix by the body.
Not at all. And the core problem with a painful perineal tear arises when this delicate, orchestrated process gets derailed. In a poorly healed episiotomy, you often see a state of uncontrolled chronic inflammation. The body essentially gets stuck in panic mode.
And when the body is stuck in panic mode, the cells doing the actual rebuilding start making, terrible decisions.
Well, absolutely terrible.
From the dermatological reviews, it seems it all comes down to a specific type of cell called a fibroblast.
Exactly, the fibroblasts.
These are the cellular workers responsible for building new tissue and laying down the collagen scaffolding. In a normal wound, they do their job, build the framework, and then quiet down.
Yeah, they pack up and go home.
But in these stubborn, painful scars, the chronic inflammation keeps the fibroblasts hyperactive way too long.
They lose all sense of regulation. Because they're constantly receiving inflammatory signals telling them the area is still under threat, they start rapidly depositing a completely disorganized scaffold of collagen.
Like a messy web.
Right. It is thick, dense, and totally haphazard. On top of that, because the tissue is demanding so much energy to keep this overactive process going, the scar develops an abnormal capillary density.
A chaotic network of tiny blood vessels forms to basically feed the panic.
Yeah, that dense vascular network is exactly what causes the persistent, angry redness and the extreme localized tenderness. The tissue is practically pulsating with excess blood flow.
That sounds so painful.
It really is. Furthermore, because the fibroblasts are just rapidly throwing down this rigid, disorganized collagen, the tissue becomes depleted of its normal, healthy elastin fibers. Elastin is what allows skin to stretch and bounce back.
So it loses all its stretch, which is disastrous for an area that requires immense flexibility.
Exactly.
It sounds exactly like a chaotic construction site. The workers completely lost the blueprint, the site manager's screaming in a panic, so they just keep pouring concrete anyway.
That's a great way to picture it.
It's bulky, it has absolutely no structural integrity, and it is taking up space it shouldn't, rigidly pulling on all the healthy tissue around it.
The clinical term for that concrete block is a hypertrophic retracting scar, or scar contracture. The tissue becomes thick, raised, and physically pulls tight.
Which causes so many secondary issues.
Right. In the vulvovaginal area, this mechanical tightness directly leads to dyspareunia, the medical term for pain during sex, along with a constant daily throbbing or tenderness just from walking or sitting.
It's awful.
The body is trying its best to heal, but it is overcompensating in the worst possible way, trapping the patient in a cycle of pain.
But here is where I have to push back on the premise of our sources.
Okay, let's hear it.
We are talking about introducing a regenerative tissue stimulator into this environment. If the body is already trapped in this cycle of overproducing scar tissue, if it is already pouring way too much concrete, how on earth is adding a stimulator going to help?
Right, it sounds counterintuitive.
Especially since the standard of care for normal scars, like applying silicone sheets, doesn't work well in the perineal area due to the constant moisture and friction. Aren't we just giving those chaotic, panicked construction workers more caffeine? It seems like it would just make the hypertrophic scar bigger and angrier.
What's fascinating here is that your intuition perfectly highlights the danger of using the wrong terminology.
Oh, really?
Yeah. When people hear stimulator, they assume it steps blindly on the gas pedal. If polynucleotides did that, you are absolutely right. It would be a complete disaster for a hypertrophic scar.
Okay, so what do they actually do?
Well, to understand why they actually heal an episiotomy scar, we have to look at their paradoxical dual-action nature. They are not mindless stimulators. They are highly intelligent modulators.
Ah, modulators. Okay, let's get into the molecule itself then. What exactly are these polynucleotides? Because the sources clarify they're often abbreviated as PNs, or polydeoxyribonucleotides, PDRN.
Right, a bit of a mouthful.
Yeah, and they really are fragments of highly purified DNA derived from the reproductive cells, like the sperm or milt of salmon or trout. Fish DNA. It sounds wild, but there's a profound biological reason for it, right?
There is. Marine DNA, particularly from salmonids, is incredibly similar to human DNA in its basic building blocks. But it is highly biocompatible and doesn't trigger our immune system to attack it.
Well, that's clever.
When it is purified and fractionated, basically broken down into specific sizes, it becomes a powerful therapeutic tool. But the most vital distinction to make here is that these are not dermal fillers.
Right, because when people hear about aesthetic injectables, they immediately think of, like, hyaluronic acid lip filler,
Exactly.
which acts like biological bubble wrap. A filler just sits in the tissue, holds onto water, and physically plumps the area up to add volume. It doesn't change the underlying behavior of the cells.
Right, it just takes up space. Polynucleotides are completely different. The research shows they are bioactive molecules. When injected, they don't just sit there. They physically bind to specific receptors on our cells.
Which receptors?
Specifically, the adenosine A2A receptors located on those overactive fibroblasts and blood vessels.
Okay, so they actually attach to the problem cells.
Yeah. By binding to the A2A receptors, polynucleotides actively communicate with the cells, delivering a set of instructions. This is where the modulation happens.
Got it.
Their effect changes entirely based on what the surrounding tissue actually needs. In healthy aging tissue that is just thinning out, yes, they encourage normal collagen production and hydration.
But what about in our messy construction site scar?
When you introduce them into a chaotic, inflammatory scar environment, they behave completely differently. They don't hand out caffeine, they hand out the original blueprints and tell everyone to calm down.
Wow, how exactly do they pull that off biochemically? Because the sources mentioned two very specific targets, HMGB1 and the NFKB pathway.
Right.
And if you're not a molecular biologist, those just look like alphabet soup. But from what I gather, HMGB1 is essentially the chemical flare gun that the damaged tissue keeps firing to tell the body to stay inflamed.
I love that analogy.
And the NFKB pathway is like the superhighway that the inflammation travels on to reach the cells.
That is a brilliant way to conceptualize it. In scar tissue, polynucleotides actively suppress HMG1. They basically put away the flare gun.
Oh, nice.
By doing that, they shut down the NFKB highway. They completely halt the chemical storm driving the panic. Once that chronic inflammation is switched off, they stop the runaway overgrowth of that messy, concrete-like collagen.
So the bad collagen stops forming.
Exactly. Instead, they force the fibroblasts to lay down highly organized collagen types I and II. They effectively fire the rogue construction workers and bring in a team of specialized architects to organize the build properly.
And they also tackle that abnormal vascular network, right?
Yes, they do.
By calming the A2A receptors, polynucleotides work to actively reduce that chaotic web of tiny blood vessels that is constantly feeding the scar.
It is a true restorative process.
Yeah.
They actively remodel the tissue back toward its healthy, functional state rather than just covering it up.
That's incredible.
And the physical size of these DNA fragments is actually the key to unlocking this whole process.
Really, size matters here.
The molecular weight is absolutely crucial. One of our dermatological reviews highlighted a study showing that the most effective molecular weight for improving the actual quality of wound healing is what they call classic PDRN.
Which is what size, exactly?
That falls precisely between 50 and 1,500 kilodaltons. A kilodalton is just a standard unit of mass used in molecular biology.
So what happens if it's too big or too small?
If the DNA fragments are too small, like below 50, they break down too quickly. If they are too large, above 1,500, they cannot optimally bind to the A2A receptors. Hitting that specific sweet spot ensures the regenerative signal is as strong and sustained as possible.
Here's where it gets really interesting.
Yeah.
We know how the molecule works in theory, right? Down on a microscopic cellular level. It puts away the flare gun and reorganizes the collagen. But theory only matters if it translates to the real world. We need to look at what actually happens when this marine-derived DNA is injected into the vulvovaginal area of real patients who are suffering from significant tissue damage and daily pain.
Oh, absolutely. And the clinical evidence is where this shifts from an interesting biochemical theory to a true medical breakthrough.
Let's hear the numbers.
We have robust data from real-world clinical studies looking at PN-based treatments specifically utilized for intimate tissue regeneration in the pelvic region.
The numbers from the study utilizing the Vaginal Health Index, the VHI, really jumped out at me. For those unfamiliar, the VHI is an objective, investigator-assessed scale.
Right, it's not just a subjective survey.
Exactly. It isn't just asking the patient how they feel. The clinician is actively measuring elasticity, fluid volume, pH balance, and epithelial integrity. The improvements recorded were massive.
They really were.
They saw a 59.8% improvement in vaginal hydration. And what is most critical for those stiff, painful perineal scars, they recorded a 50.9% improvement in deeper tissue elasticity.
Which is huge. When you're trying to resolve a scar contracture, elasticity is the holy grail.
Right, because it's so tight.
The entire reason an episiotomy scar hurts during movement or intimacy is because it cannot stretch. It only pulls. When the tissue regains half of its natural ability to stretch and flex, the physical tethering that causes the day-to-day pain begins to fundamentally subside. The structure of the skin is literally changing.
And the symptom relief absolutely backs up those physical changes. And this is where we have to translate these percentages into actual human experience.
Definitely.
The study tracked patients out to day 90 of the treatment protocol. By day 90, patients reported a 59.4% reduction in dyspareunia. They saw a 70.1% drop in soreness and tinkling and a 54% reduction in general irritation.
Those are staggering results.
I'll put that in perspective. Imagine a woman living with daily localized pain at a level 8, where sitting at a desk or being intimate with her partner is just agonizing.
Yep.
Suddenly, that pain drops down to a 2. That is not a marginal statistical tweak. That is getting your life back. Cutting chronic pain by 60 to 70% is completely life-changing.
It restores a sense of normalcy that many of these patients thought was gone forever.
Exactly.
And to understand why we can trust that these polynucleotides are actually remodeling the scar tissue itself and not just acting as a temporary numbing agent, we can look at a randomized controlled trial that focused on post-surgical scars outside the pelvic region.
Oh, right, the one on the neck scars.
Yes. Specifically, they looked at scars from open thyroidectomy surgeries.
Which initially feels like a weird tangent, honestly.
Yeah.
Why study thyroidectomy scars on the neck when we are trying to understand the pelvic floor?
I know it sounds disconnected, but the neck is a highly visible area prone to constant mechanical movement and tension.
Ah, I see.
Every time you turn your head, swallow, or speak, the skin stretches. That constant mechanical stress makes the neck an excellent observable model for studying why scars become hypertrophic.
And the pelvic floor is under similar constant mechanical stress.
Exactly. The trial showed that early injection of PDRN into these neck scars significantly lowered the vascularity and actively prevented them from becoming thick and hypertrophic.
Wow.
It serves as a definitive proof of concept. Injecting these specific DNA fragments rapidly decreases wound erythema, the redness, and halts the excessive scar formation, regardless of where it is on the body.
If you are trying to picture the real difference between traditional topical treatments and polynucleotides, think of it this way. If injecting hyaluronic acid or applying a thick silicone gel is like spreading a really nice layer of spackle over a crack in your wall to smooth it out and hide it,
Right.
well, polynucleotides are like hiring a structural contractor to actually go in, pour new concrete footings, and rebuild the wall's entire foundation so the crack fundamentally ceases to exist.
Yeah, and if we connect this to the bigger picture, what we are witnessing is a massive paradigm shift in intimate health.
It really feels like a new era.
We are moving away from purely symptomatic relief like prescribing a topical lubricant, a mild steroid cream, or a numbing gel, and moving toward actual biological repair. We are asking the tissue to fix itself and providing it the exact genetic messaging it needs to execute that repair.
Rebuilding a foundation sounds incredible in theory, but practically speaking, when we are talking about a pelvic floor, the reality of rebuilding sounds like it involves needles in a highly sensitive area.
That is the tricky part.
For a listener who is actually considering this for their own painful episiotomy scar, we need to demystify what the physical protocol looks like. How are clinicians actually pulling this off without traumatizing the patient further?
The clinical application is highly refined to prioritize patient comfort. We have detailed protocols drawn from practices like the Door Clinic and various Harley Street clinics, which give us a very clear step-by-step picture of the real-world experience.
So what's the first step?
The treatment does involve microinjections. After a thorough assessment to map out the scar's specific morphology and tension points, the clinician uses a very fine needle to deposit the polynucleotides directly into the superficial layer of the scar bed and along its outer edges.
Just right into the skin?
It is a precise delivery into the dermis, targeting exactly where those hyperactive fibroblasts are trapped.
I think it is important to set realistic expectations here for anyone listening. Based on the 12 to 18-month natural healing timeline we discussed earlier, this is clearly not a one-and-done magic wand. You don't walk out of the clinic an hour later with a brand new pelvic floor.
Not at all. Because we are relying on the body's own cellular turnover and the gradual reorganization of the collagen matrix, this requires patience.
How long does it usually take?
A typical course of treatment is about 5 sessions, usually spaced 2 to 3 weeks apart. Though, depending on the severity of the scar's fibrosis and how old it is, some milder protocols might only call for 1 to 3 sessions.
Okay, so a few months of treatment.
Yeah, the clinical guidelines suggest that noticeable structural results take about 6 to 12 weeks to become apparent. The tissue literally needs that time to physically digest the bad collagen and rebuild the healthy matrix.
Now, what if the scar is much older? Say, a severe perineal tear or a complicated C-section scar from 3 or 4 years ago. Scars that have become deeply tethered, where the fascia is essentially glued to the underlying muscle, creating deep, painful indentations.
For those older, deeply tethered scars, polynucleotides are rarely used in isolation. They are often stacked with other modalities.
Stacked? Like what?
A clinician will frequently use a technique called subcision. This involves using a specialized needle to mechanically sweep under the scar, physically breaking up and releasing those hard, fibrous bands that are anchoring the skin down.
Oh, wow. That sounds intense.
It sounds it, but it's very effective. Alternatively, they might use fractional lasers to create controlled micro-injuries that stimulate the surface.
And then the polynucleotides are added.
Exactly. The polynucleotides are then immediately layered into the tissue following these physical procedures. They act as the biological blueprint to ensure that when the tissue recovers from the subcision or the laser, it heals correctly this time around rather than just forming another hypertrophic scar.
I have to ask the elephant in the room question. We are talking about an area that is already incredibly tender, sensitive, and prone to pain. Injecting an already inflamed perineal scar multiple times or sweeping a needle under it for subcision sounds agonizing.
I know, it sounds really daunting.
What is the downtime and how are patients actually tolerating this process?
Well, the clinics are acutely aware of the sensitivity of this region. Patient comfort is paramount. A strong prescription numbing cream or a localized anesthetic injection is always utilized prior to the procedure to minimize discomfort.
So they aren't feeling the actual needle much.
Right, you are not feeling the sharp pain of the injections. As for the downtime, post-treatment recovery is surprisingly mild compared to what you might expect. Because polynucleotides are naturally derived from marine sources and are highly biocompatible, there are no severe systemic side effects or allergic rejections.
So no weeks of bed rest or intense recovery.
Not at all. Patients typically experience transient redness at the injection sites, perhaps some slight bruising, and localized tenderness that lasts for a day or two.
Sort of like a bruise.
Exactly. It's similar to how you might feel after a mild workout or a minor scrape. There is no severe tissue peeling, no burning sensation, and no prolonged recovery window like you see with aggressive resurfacing lasers.
That's amazing.
It is considered a highly tolerable walk-in, walk-out procedure. This makes it an incredibly accessible option for mothers and working women who simply cannot afford weeks of downtime.
So what does this all mean? Let's recap what we've unpacked today. We started by looking at why poorly healed perineal tears and episiotomies cause so much ongoing grief.
Right, the rogue healing process.
Yeah, it comes down to a healing process gone completely rogue. Disorganized collagen, persistent abnormal blood vessels, and chronic inflammation create a rigid, painful scar contracture that physically pulls on the surrounding healthy tissue, turning daily movement and intimacy into a source of pain.
And we then explored how polynucleotides, highly purified fragments of salmon or trout DNA, step into that chaotic environment. They don't just mask the issue or plump the tissue.
No, they do so much more.
They act on a deep cellular level. They bind to the A2A receptors to put away the inflammatory flare gun, switch off the runaway scar-building signals, and force the fibroblasts to reorganize the collagen into a healthy, flexible matrix.
The result, backed by the clinical studies, is restored elasticity, significantly improved hydration, and a massive, life-altering reduction in daily pain, all without relying on hormonal treatments, which is a huge relief for women who either cannot or prefer not to use topical estrogens.
It really is a game changer.
The biggest takeaway here is a message of agency. You do not have to simply live with intimate discomfort or painful scarring after childbirth. For too long, that has been the default, dismissive medical answer.
Just deal with it, essentially.
Exactly. But regenerative medicine is offering tangible, proven tools that actually rebuild the tissue's foundation, rather than just masking the pain or telling you to wait it out.
This raises an important question. For decades, women's postpartum pain, specifically the lingering trauma of perineal tearing, has been broadly dismissed by the medical establishment as just part of the process.
Yeah, sadly.
Something to be quietly endured because there was no easy pill to fix it. But if marine-derived DNA can fundamentally rewrite the way our bodies heal these deeply intimate, historically ignored scars, what other inevitable physical traumas are we just days away from being able to reverse?
Wow, that's a powerful thought.
We are literally unlocking the genetic building blocks of the natural world to teach our own cells how to heal properly.